to the prevention of and response to emergencies due to food and allergic reactions training. This training will cover information on the causes of allergic reactions, what children experience when having a reaction, how to care for children in these situations, and how to prevent reactions from occurring in your facility. As you go through this training, you will notice a green icon along with the word Resources in the upper right portion of your screen. Clicking the icon will open a window with information on the images used in this presentation. Clicking the Resources will allow you to learn more about the information used to create this training. In addition, some slides contain images, videos, or links that make this presentation more interactive. Clicking on these links will open information in new areas and will not impact the presentation view. This presentation also gives you the option to view subtitles, pause the slide, or replay the slide from the beginning. You may navigate to all the slides within the presentation using the sidebar on the left, but all slides within this presentation must be viewed in order for you to continue. This training provides trainees with information on prevention and response to emergencies due to food and allergic reactions. In partnership with the North Carolina Department of Health and Human Services, this training is being offered by the NC Childcare Health and Safety Resource Center, a program of the University of North Carolina at Chapel Hill, and is intended to meet applicable NC childcare rules set forth under 10A NCAC 09.1102 Centers and .1703 FCCH. Those who satisfactorily complete the training will receive a certificate of completion for 1 contact hour. The university does not require this training. Completing this training does not qualify participants as certified medical or healthcare professionals, nor does it replace the need to consult a healthcare professional for guidance. Nothing in this training, including any and all contents, materials, or information provided as part of this training, is or should be considered or used as a substitute for medical advice, diagnosis, or treatment. Never disregard or avoid professional medical advice or delay in seeking it because of something you have read, heard, or seen as part of this training. Contact a child care health consultant for implementation guidance. Today's presentation will cover types of allergies, reducing the risk of allergies, symptoms of allergic reactions and anaphylaxis, emergency follow-up procedures, storage of epinephrine auto-injectors, and documentation for treating a child with known allergies. Think about what you should do in the following situation. A toddler tastes a fish stick for the first time in your classroom. Within minutes, she begins to complain of her mouth burning, and you notice she has a rash spreading on her neck, but she does not have any known allergies. She begins to wheeze, and her skin turns pale. Throughout this training, you will learn how to properly react to this situation. Let's begin by discussing what an allergy is and how it can impact a child's body. The body's immune system fights bacteria and viruses and protects the body from diseases. Allergies are the response the body has when the immune system mistakes a harmless substance, such as airborne particles, certain foods, insect stings, or chemicals, as dangerous and attack it. These normally harmless substances are called allergens. The body responds to allergens by releasing histamines and other chemicals to fight off the invader, causing the allergic reaction. Common airborne allergens include dust mites, pollen, molds, cockroach droppings, and pet dander, the tiny flecks of skin shed by cats, dogs, rodents, birds, or other animals. Common food allergens are cow's milk, eggs, fish and shellfish, soy, tree nuts such as hazelnuts, pecans, almonds, and walnuts, peanuts, and wheat. Other common allergens are insect stings, such as those from bees, wasps, or fire ants, medications, chemicals, and latex, which may be found in toys or bouncy balls in addition to some types of gloves. Take a moment and think of children in your center who have allergies. What are they allergic to? How do allergies impact these children? How many of them have serious, life-threatening allergies? Later in this training, you will learn more about anaphylaxis, the most serious allergic reaction that can be fatal if not recognized and treated quickly. The prevalence of food and skin allergies among children has increased in the last 20 years, and allergic reactions to foods have become the most common cause of severe allergic reactions, known as anaphylaxis. Anaphylaxis is very dangerous and can be life-threatening. A food allergy is not the same as an intolerance. With intolerance, also known as sensitivity, some of the symptoms can be similar, but the immune system is not involved. If a person eats a gallon of ice cream and gets a stomachache and gas, it is likely an intolerance rather than an allergy. Allergies and asthma often go hand in hand. Many allergens are also asthma triggers and cause irritation and swelling in the child's airways. Asthma symptoms such as wheezing, breathlessness, chest tightness, or coughing can occur. Allergies can also cause children with asthma to have more severe allergic reactions when exposed to an allergen. Let's talk now about the symptoms and treatment of mild allergies. Allergies that can certainly cause us to feel miserable but are not life-threatening. Families and early educators should work together to keep children safe through good communication and coordination, including an infant feeding plan. New foods and medications should always be introduced at home before being offered in childcare. When foods are being introduced, doing so slowly and one at a time will help to identify problems or allergies early. Help parents understand that they should start with single-ingredient foods that are unlikely to cause an allergic reaction. After 3 to 5 days, families should introduce a new food and make sure each is being tolerated. Continue this process until a wide variety of foods has been introduced, including foods like eggs, dairy, peanuts, and other foods that are common food allergens. This practice may help avoid the child developing food allergies. However, if the child has a family history of food allergies or develops symptoms of eczema, the family should contact their child's healthcare provider before proceeding. Ask families to update allergy information and prescribed treatment annually. Encouraging and supporting breastfeeding in your facility has many positive health benefits for the child and strengthens their immune system. It is least likely to trigger an allergic reaction, it is easy to digest, and it strengthens the infant's immune system. Especially recommended for the first 4 to 6 months, it may possibly reduce early eczema, wheezing, and cow's milk allergy. For infants at risk for food allergy where the mother is unable to breastfeed, hydrolyzed infant formulas are recommended as hypoallergenic substitutes over cow's milk and soy formulas. To reduce environmental allergens, facilities should be sure all rooms used by children are heated, cooled, and ventilated to maintain comfortable temperatures and humidity level. The relative humidity indoors should be kept between 30 and 50%. Be sure spaces are ventilated by having screened windows that open or by means of mechanical ventilation to the outside. Keep all ventilation equipment, including windows, window treatments, heating and cooling vents and return grills, fans, etc., clean and in good repair. Clean air filters to keep animal dander down. Keep animals out of the child care environment if necessary. Reduce items that collect dust, such as rugs and soft toys. Vacuum, dust, and wash items such as pillows, soft toys, and fabric that collect dust when children are not present. Clean carpets, pillows, soft toys, and fabric often to remove dust from the environment. Wash and dry areas such as counters, sinks, and tabletops to reduce mold. Check pollen count and close windows and stay inside if pollen is high. Mild allergy symptoms are familiar to everyone. Seasonal allergies to pollen, sneezing and itchy eyes when petting a cat, or hives after taking a new antibiotic are examples of mild allergic responses. Not all symptoms are necessarily present at the same time. These types of responses occur between 2 minutes and 2 hours of exposure to an allergen. Exposure to the allergen may be through touch, swallowing, or inhaling the allergen. Some allergens can't be entirely avoided. In these cases, medications may be prescribed for the child to take on a routine basis or as needed when allergy symptoms worsen. Antihistamines reduce or block the immune system's histamine response. Histamine is responsible for most of the symptoms of allergies as well as colds. This includes itchy, watery eyes, itchy, runny nose, sneezing, mild rash or hives in the skin, and stomach cramps and diarrhea. Examples of antihistamines are Benadryl, Allegra, Claritin, or Zyrtec. Note that some antihistamines may cause drowsiness or a dry mouth, nose, or throat. Corticosteroids are powerful medications that may be prescribed for children but should be used very carefully. Corticosteroids work by reducing swelling and irritation. They can come in several forms. Nasal, such as Nasonex or Flonase, to decrease swelling in the nose or sinuses. Inhaled, for use in an inhaler or nebulizer to decrease swelling in the lungs in a child with asthma symptoms. Topical, like hydrocortisone cream or ointment for a rash on the skin, or as an oral medication like prednisone for serious inflammation. The side effects of corticosteroids can be serious, and you should never use more than the recommended amount or more often than instructed. Learn the side effects of the medications you give to children and report any that you see to the director and the child's parent or guardian. The next section will talk about a much more serious reaction to allergens called anaphylaxis. Anaphylaxis is best described as a severe allergic reaction that is rapid in onset and may cause death. Not all allergic reactions will develop into anaphylaxis. In fact, most allergic reactions are mild and resolve without problems. It is not easy to predict whether these initial mild symptoms will progress to become anaphylaxis. However, when they do progress to anaphylaxis, it can happen very quickly and can result in death. Anaphylaxis often begins within minutes after exposure. Less commonly, symptoms may begin hours later. Up to 20% of people have a second wave of symptoms hours or even days after their initial symptoms have been treated. Anaphylaxis can occur after exposure to an allergen that is known to cause a severe reaction, such as a peanut to a child with a known peanut allergy, has caused only a mild reaction before. For example, a child who has previously had only a mild rash after eating fish, suddenly having a severe reaction to fish as an ingredient in a sauce. Or exposure to an allergen that was unknown to cause any reaction at all. For example, a child who has had a bee sting previously with only pain or itching at the site of the sting has a severe allergic reaction the next time he is stung. Now that you know that severe allergic reactions can occur even when you are not expecting them, let's look at the allergens that are most likely to cause anaphylaxis. Some allergens cause mild symptoms, like sneezing or itchy eyes, and others are more likely to cause anaphylaxis. Foods, medications, latex, and stinging insects are the most common causes of anaphylaxis. In children, the most common foods that cause anaphylaxis are milk, eggs, and peanuts. Recognizing anaphylaxis is crucial to avoiding a child's death. Each area of the body, the mouth, throat, digestive system, lungs, heart, and skin, are affected in different ways. This section will include images and videos describing what anaphylaxis looks like in these different areas of the body. Around the mouth, significant swelling of the tongue or the lips is a danger sign. Children experiencing an allergic reaction may describe their feelings in unusual ways. Some children, especially very young ones, put their hands in their mouths or pull or scratch at their tongues in response to a reaction. A child's voice may change often, becoming hoarse or squeaky, or they may slur their words. In the skin, look for many hives over the body and widespread redness. Keep in mind that hives may look different on different skin tones. In the throat and lungs, watch for tightness, hoarseness, trouble breathing or swallowing, shortness of breath, wheezing, and a repetitive cough, as well as a high-pitched cry or cough. Because children with asthma have airways that are already vulnerable, children who have allergies, in addition to asthma, are likely to have a bad outcome of anaphylaxis. Repeated vomiting and severe diarrhea are two signs of a severe allergic reaction that can affect the gut or digestive system. Anaphylaxis can also affect the heart, causing a weak pulse, dizziness, and fainting. The child's skin may be discolored and appear pale or blue. If a child has symptoms of anaphylaxis, including at least one symptom in 2 or more body areas, you should treat the reaction as an emergency. If a child has a known severe allergy, the child's health care provider may direct you to treat as if the child was exposed to an allergen, even if no symptoms are apparent. For example, if a child has a known severe reaction to a bee sting and they are stung on the playground, there may be instructions from the child's doctor to treat the child even before they start having symptoms. Later, you will be given more information about these instructions from the healthcare provider, known as a medical action plan. Always be prepared. Anaphylaxis is a medical emergency. Epinephrine, also known as adrenaline, is the only medication to treat anaphylaxis. Never try giving other medications, such as Benadryl, instead of epinephrine if there are symptoms of anaphylaxis. Epinephrine works by narrowing blood vessels, which keeps the blood pressure up, opening airways in lungs to improve breathing, and stimulating the heart to increase heart rate. A trained person should give an epinephrine autoinjector, such as EpiPen Jr., immediately to prevent shock and death. If there is any doubt about the reaction, it is better to administer the epinephrine. Call or have another person call 911 immediately as the epinephrine is being given. If no epinephrine is available, tell the operator that it is not available. If symptoms worsen, the child may need a second dose. Tell emergency responders that a child is in anaphylaxis and may need more epinephrine. Once the immediate life-threatening concerns are taken care of, either by someone in your facility or by emergency responders, call the child's parent or guardian. If a person is experiencing anaphylaxis at your facility but does not have an epinephrine autoinjector assigned to them because they do not have known allergies, call 911 immediately. Explain that a person is having an allergic reaction and that epinephrine may be needed. To prevent a life-threatening situation, North Carolina law allows child care facilities to acquire, stock, and administer epinephrine autoinjectors when any person, child or adult, without a known allergy experiences anaphylaxis. Healthcare providers are allowed to prescribe non-child-specific epinephrine autoinjectors in the name of the child care facility. To give epinephrine, the early educator must have completed training on administering epinephrine and believe, in good faith, that the person is experiencing anaphylaxis. For an early educator to administer medication without parental authorization, all of these conditions must be true. It is an emergency medical event, the child's guardian is unavailable, and a medical care provider must give permission and their instruction must be followed. The law does not require a child care facility to acquire, possess, store, make available, or administer epinephrine. It protects them if they choose to be prepared to provide first aid for anaphylaxis. Giving epinephrine is not covered in this training. Contact a child care health consultant or nurse to learn how to administer an epinephrine autoinjector. He or she will have a trainer that they can practice using. Also, you can take the Medications in Child Care and Medication Administration Skills trainings for more information on this topic. Any emergency causes upset and fear for the child affected, the other children who have witnessed the emergency, and the early educators who are caring for the child. The adults in charge must remain calm and focused. After the epinephrine is given, stay with the child. Check that emergency personnel are on their way and be ready to start CPR should the child's condition worsen. Keep the child warm and lying on their back with their legs elevated. If the child vomits or has trouble breathing, turn the child onto their side. Once epinephrine has been given, other medications the child is prescribed on the medical action plan can be given. Though there may be other medications listed on a medical action plan that a child should receive in addition to epinephrine if a child is experiencing anaphylaxis, epinephrine is the only medication that works quickly and provides life-saving treatment. Because of the way epinephrine works, some reactions are to be expected, including a faster heartbeat or a headache. If these are severe, let emergency personnel know. Other side effects may include sweating or dizziness, nausea or vomiting, weakness or shakiness, feelings of overexcitement, anxiety, or fear. About 20% of people may require a second dose of epinephrine due to ongoing symptoms. A second dose of epinephrine may be given, if available, if symptoms of anaphylaxis worsen, continue and do not improve, Return before emergency personnel arrive after 5 to 15 minutes. As with the first dose, write down the time the medication was given and keep the second used autoinjector to give to emergency personnel. As we've talked about in previous slides, 911 must always be called when an epinephrine autoinjector has been given. Explain the situation and answer any questions they have. The used epinephrine autoinjector should be kept to give to emergency personnel. The emergency personnel and other healthcare professionals must continue to monitor and evaluate the child. In some cases, it may look like the anaphylaxis is over, but the child may begin experiencing symptoms again. When a child or adult without a previously known allergy experiences anaphylaxis and is given a dose of epinephrine from a stock supply, it's important to record as many details as possible to provide the child's family and healthcare professional with the information they need to identify the allergen and reduce the child's future risk. The child's emergency contact must also be notified immediately if anaphylaxis occurs. To do so quickly, keep emergency contact information up to date, bring emergency contact information to the playground or on field trips, and when speaking to the child's family, let them know whether emergency personnel will be taking the child to the hospital or not. If the family is unable to arrive before the child is transported for further care, the person designated to accompany ill or injured children during an emergency should be ready to leave. Nearly all medications in childcare must be stored in a locked cabinet or container. In all childcare facilities, both centers and family childcare homes, an exception is allowed for emergency medications that need to be easily accessible in case of an emergency. These medications should not be stored in a locked cabinet or container. They must be stored inaccessible to children, at least 5 feet from the ground on a sturdy shelf or hook. Examples of emergency medications include epinephrine autoinjectors for allergies, glucagon for diabetes, diazepam suppositories or gel for seizures, and certain asthma rescue inhalers. Other medications, such as diphenhydramine, commonly known as Benadryl, are not emergency medications and must still be stored in a locked container. Here is some additional information on the storage of epinephrine and other emergency medications. Store the medications in a red fanny pack or backpack on a high shelf or hook near the exit to the playground. Keeping the backpack near the playground exit should make it easier to remember to take it with you. While on the playground, keep the fanny pack or backpack on your body or store it above 5 feet. Inside the backpack or fanny pack, keep each child's medication and necessary documentation in a plastic storage bag labeled with the name and picture of the child. If the temperature outside is extremely hot or cold, place autoinjectors in an insulated bag inside the backpack. Also on screen is an image of the individual child's packet. It includes the child's picture and name, the signed medication administration permission and record, and the allergy action plan. Remember to update information and picture as necessary and at least every 6 months. If an epinephrine autoinjector has been used in an emergency or has expired, be sure you get a new dose right away. A replacement autoinjector should be available as soon as possible. If the epinephrine is for a specific child, ask the parent or guardian to bring a new autoinjector when the child returns to the classroom. Anaphylaxis can happen to anyone at any time. As we have already discussed, an insect sting or certain type of food may suddenly cause anaphylaxis in a child or adult with no previous allergies at all. Having epinephrine available for children in your care and your coworkers can save lives. At the beginning of this training, you saw this situation. A toddler tastes a fish stick. Within minutes, she begins to complain of her mouth burning. You also notice a rash spreading on her neck, but she does not have any known allergies. However, her lips and tongue start to swell. What should you do? This child may be having an anaphylactic reaction, even if there is no known history of allergies. Remain calm. Call 911 immediately or have someone else do so. The 911 operator will contact emergency medical services. While on the phone, the operator will likely ask questions to get a better sense of the situation and to provide you with instructions that can help save the child's life. This may include first aid, removing the allergen from the child's presence, moving the child into a position where she is on her back with her legs raised, or moving her onto her side if she is vomiting. CPR may need to be started if the child's condition worsens and she is no longer breathing or does not have a heartbeat. If your facility has a non-child specific epinephrine autoinjector stocked for use in an emergency, have a trained person administer it. Your role is to keep the child as stable as possible until emergency medical services arrive. Once they are on site, be sure to give them any information or materials they need, including the autoinjector, if used. Thank you for your time and attention in this training. As you have seen, allergic reactions can quickly progress to life-threatening emergencies. Knowing how to recognize, respond to, and prevent these situations in our environment is key to keeping a safe facility. Continue on to complete the training and earn your certificate.
Children will enter your program with a variety of dietary needs. When planning menus and cooking meals, you should be prepared to serve children with a range of allergies.
The allergy listing that we publish on a monthly basis or update as needed goes into the classroom. That list includes pictures and names of each child that has an allergy and what he or she is allergic to. We're responsible for making sure the staff is aware of them, and they're located in the same spot in every classroom so that as staff float in and out, they're aware of them. And then when the meal time comes, we ask that the staff verify, number one, that there are any children at the table that are sitting, have an allergy or at the table, so they can cross-reference that name to face or that picture to the face and make sure they're serving the right food to the right child. All of our allergy food comes on blue plates right now, and it comes with, we choose to label them with what the child's name and what their allergy is to double check. And then if any time the staff is unsure whether the toast is wheat or white, then they can always buzz back to the kitchen to verify that as well. My biggest role is going to be interacting with the parents, pulling that information out from them, coming up with that emergency action plan if the child were to be exposed, and then more importantly is worrying about what kind of substitutions we're going to make from it. So, and then relaying that information off to the kitchen, overseeing making sure they're doing what they need to do, and then secondarily following up with the staff in the classroom to, number one, make sure that they know what's anticipated and what the child can and cannot have, and then making sure it's posted in places that if unfamiliar staff come in, that they're aware, and the responsibility for that part as well. I'm sure you've seen or should have seen in the kitchen that we have pictures posted both in the classroom and in the kitchen, and they're posted on our tables in our classrooms as well as a safety precaution to make sure that the right child always gets the right food.
We're unique in that we have a allergy person that she tends to the 50 kids. Today for lunch was the spaghetti. This morning I cooked the beef for it. She took some beef out, and out of that beef she made beef and noodles for the citrus children. She made pasta with spaghetti sauce for the vegans. If we can't change the menu enough to make it appropriate for the most part, we don't fool with that. We have special plates, the blue plates for allergy children. So when the caregivers, when the food comes in the room, there's a blue plate that goes to the allergy child. And all the rooms have a little place card on the table with the allergy, the kid's picture, the child's picture, the allergy, and so everybody knows. The ones there, they got a blue plate, and they have a blue plate on the cart. Everybody else has got just bowls of food and the blue plates for the allergies.
So really it's just a matter of making sure the staff are well trained and making sure they get to the training or providing them the training that they need.
By working with parents and center directors, keeping records, and properly training food service employees, you can monitor and protect children from food allergens.